Hello. My name is Haney Malamat, and I'm your host for the Cooper Critical Care Podcast. Last time on the podcast, Emily Damuth was speaking to us about taking care of the critically ill pregnant patient. This week, we're shifting gears a little bit, and we're going to be talking about sepsis. Dr. Jen Axelband is going to be taking us through and talking about the different scoring systems to see which one is the one we should be using when we meet our patients for the first time. Before we get there, let me just tell you that the C4 conference, or the Cooper Critical Care Conference, is shaping up to be a really amazing conference. That's happening on March 20th, 2019, right here at Cooper Hospital. So if you're a trainee, tickets are free. You can't beat the price. And if you're an attending, tickets are going to be a reduced price for you, and we're going to have CME available. For both trainees and attendings, there's going to be afternoon workshops. This will be either basic or advanced airway or basic or advanced ultrasound. Spots are extremely limited because we're keeping this workshop small. We're keeping them small because we want you to have a good experience, one-on-one teaching with your instructor. So stay tuned for details when these tickets are released, because I guarantee you they're not going to last for long. Let's get right to the podcast with Dr. Jen Axelband. She's going to be speaking about QSOFA, SIRS, NEWS, what scoring systems we should be using for our patients when they present with sepsis. So here we go, Dr. Jen Axelband.
Hi, good morning. Happy first day of spring. We're getting a nor'easter. Isn't that great? I do practice in the intensive care unit as well as the emergency department, so screening tools for sepsis is what I get to talk about, which I use in the ED, on the floor when I get called to see a patient, as well as when I'm in the ICU to see if somebody's getting worse. So the question is which one works and what should we use? So putting this all together, my son started watching The Big Bang Theory lately. You guys seen this show? Sheldon Cooper, appropriate, as we're at Cooper, is constantly sick, and he loves his sofa. Sofa has caused a lot of discussion lately and a lot of controversy. And I went backwards. Oops, sorry. So I have nothing to disclose, just so you know that. Nobody wants to give me any money for any reason. But what we need to think about is, what are we doing? There's so many choices, so many things to think about when we're screening for sepsis. So who are the big guns that we have to deal with? We have to deal with CMS. We have the Surviving Sepsis campaign. We have the different areas of where we work. We work in the ICU, we work in the ED, we work on the floors. What do we use to determine if a patient is sick enough that we need to be concerned that they're going to decline? So again, looking at CMS, what do they want? Hospitals are saying, hey, we get paid by these guys. We have to meet their guidelines. I don't care what the new literature says. I don't care if CMS is 3 years behind. We need to follow this. Or do we need to look at, what is the Society of Critical Care Medicine saying? They're like saying one thing with ESICM in regards to the SEP3, which is the new controversy that's come out in regards to, should we use QSOFA, should we use SIRS? Those are the two big screening tests that we all are very familiar with. In the UK, they use other things. They use a NEWS score. We also have Muse scores, which we do use here as well. There's a bunch of other ones, all different types of words and algorithms, but as far as what we use, these are the four big ones. So talking about SEP3. So SEP3 defines sepsis totally different from what we're used to. A lot of us grew up knowing 2 out of 4 SIRS criteria plus infection, sepsis. They're now describing it as a physiological response to infection that's causing derangements and causing somebody to be sick. And then they take that and they excluded severe sepsis, and now they're looking at just sepsis and septic shock. Septic shock is when you have persistent hypotension despite fluid resuscitation and you can't maintain your MAP and you need vasopressors. So whole new definition, whole new screening. They compared, looking at QSOFA, they looked at actually SOFA compared to SIRS, and we'll talk about that in a second. And then they came up with this screening tool of QSOFA and recommending that's what we should use because SIRS is not useful. So they're saying here that infection crosses over with QSOFA, gives you sepsis, and can give you septic shock. So what we're used to seeing, completely different. And they're saying that from what they did in this study, that we should be looking at hypotension with a systolic blood pressure less than 100, respiratory rate greater than 22, and altered mental status. Altered mental status, they went back and forth a little bit describing what that actually means, but they're saying a GCS less than 15. CMS, and this is what we all kind of learned as we were going through school, going through residency, going through training, goes by 2 out of 4 SIRS criteria plus a source of infection. And that's what you need to have documented by all your coders in order to get your hospital reimbursed, and then back to the reporting systems that are coming out and comparing hospitals. They're all looking at how well you screen for sepsis, treat sepsis, diagnose sepsis, and what your mortality rates are based on what CMS says. So we have this SEP3, which is from the 19 experts of the Society of Critical Care Medicine and ESICM, saying you need to use QSOFA. And then we have CMS, which is the US system that's standardizing everything, saying you need to use SIRS plus 2 SIRS criteria plus infection. So, SSC, what do they say? They're really kind of non-committal. They're the European Society, they're SCCM, and they're saying, you know what, you need to identify infection, and you need to look for infection based on clinical signs and symptoms, but they're not really saying you need to use SIRS criteria. They're not saying you need to use QSOFA. They're kind of just saying you need to do some kind of screening. Interestingly, though, when you pull up their worksheets and some of the information they have available for hospitals starting up a sepsis program to do all their screening, they have this up there, which basically goes off of SIRS, except for on the second part, they talk about hypoglycemia, and they do have altered mental status in there. So what do they truly recommend? It seems like they're still with SIRS. And from what their response is to the SEP3, is they're saying evidence of 2 out of 3 QSOFA elements in patients who have screened positive for infection may be used as a secondary screen. So they're not advocating it be used as a primary screen. They're saying it's important first step in screening is to identify infection. And then they don't really go further as to what you should use. In their memo, they do comment that everybody should continue along the same spectrum right now, that to be prepared, maybe there will be changes in the future, but they are truly non-committal as to QSOFA versus SIRS. So truly, what do we need to do in clinical practice? How do we save lives, and how do we manage patients? It comes down to sensitivity, specificity, and mortality of patients. So what do we have to say about that? Our most popular scores, as I talked about, were SIRS, QSOFA, MUSE, NEWS, and these are the scores that have the most studies published. And looking at the MUSE and NEWS scores over here, MUSE scores, some hospital systems use them to look at patients, particularly on the inpatient side, to see if there's a change. The National Early Warning Score, the NEWS score, is used in the UK, and that's used in their emergency departments as well as on their floors. So the literature, what does the literature have to say about all of this? What they're saying is, in this one from 2016, is looking at if there's clinical deterioration outside of the ICU. And what they looked at was area under the curve. So area under the curve is basically telling us how somebody does from a mortality standpoint. So looking at best to worst, if you hit somewhere close to 1, that's pretty good as far as a predicting score. NEWS score is extremely high. So that's telling us that NEWS score predicts mortality really well compared to QSOFA as well as SIRS. But what does that mean to us? Well, if you look further into the study, 91% of those patients that declined and were transferred to the ICU or died had 2 out of 4 SIRS criteria, compared to 54% having 2 QSOFA scores. Also, the majority of patients 17 hours prior to having transfer or dying had 2 out of 4 SIRS criteria. 5 hours prior, QSOFA became positive. So SIRS was a little bit more sensitive in detecting when somebody is declining. Looking at this study, it's looking at the ICU admissions and mortality from the ED. Again, looked at NEWS, SIRS, and QSOFA. And as you can see, sensitivity, which is it positive in disease, SIRS is 80%, QSOFA is 37%, so not very sensitive in detecting disease. Specificity is much higher for QSOFA, but what does that mean? So if we're sensitive, we're picking up a lot of patients, we're getting a high catchment, we're not losing those patients that potentially could be sick. So yes, we may have some false positives. Specificity, it's like, are we identifying those patients more that aren't at risk? So what is more important? Is it more important to identify those patients at risk or identify those patients not so much at risk? And then looking at the area under the curve for death, NEWS score was definitely higher compared to Q-SOFA as well as SIRS. So again, another study looking at what's better for discrimination of in-hospital mortality. SOFA was 0.73, Q-SOFA 0.67, SIRS 0.58. Again, this is looking at area under the curve. So for mortality, SOFA was a better score than Q-SOFA, which to be expected because Q-SOFA is derived from SOFA, and SIRS wasn't as predictive of mortality. But is it mortality that we're looking at, or is it the risk of a patient declining? And that's where you have to interpret all these studies pretty carefully and then incorporate them into your practice. And again, another study. So the area under the curve for Q-SOFA, 0.80 as predicting mortality, but the sensitivity is only 70% compared to SIRS, which was 93. So you're picking up a lot more patients with those SIRS. We had a great study that was just done in the Annals of Internal Medicine in 2018, which took over 300,000 patients and compared it all for us. So looking at these individual studies is very helpful, but it's always nice when somebody does the work for you and figures it out. So looking at sensitivity for SIRS versus Q-SOFA, overall, higher sensitivity for SIRS. In the ED, higher sensitivity. In non-ICU patients, higher sensitivity for SIRS. Specificity, so saying those patients aren't so sick, was higher for Q-SOFA overall. So everywhere we're seeing SIRS is more sensitive. So how do you use this in your practice? I don't know. The majority of sepsis we know is diagnosed in the ED, so sensitivity is going to be key. We don't want to miss any of those sick patients, so that's something to consider. Surviving sepsis guidelines really don't say anything about Q-SOFA. They're kind of like in between saying, hey, maybe there's going to be a change, maybe there won't. Q-SOFA tells us that somebody has a severity of illness. It really doesn't pick up all of those patients and screen very well. Neither score is perfect. We know it probably lies somewhere in the middle. And then sepsis is a spectrum of disease. Looking quickly at SIRS, Q-SOFA, MUSE, NEWS. SIRS, again, has those parameters. Q-SOFA has components of MUSE and NEWS in it. So, of course, MUSE and NEWS are going to be better at predicting mortality because Q-SOFA has elements of those two. But there are much more elements, and there's a much more complex scoring system for MUSE and NEWS. This goes back to step 3. So the step 3 study, which is saying Q-SOFA should be used as your screening tool and SIRS is not useful, basically says, are patients suspected of having infection? And if so, you should do a Q-SOFA score. But then look what happens after that. So if so, yes, then you should do a regular SOFA score. So in this study, they actually compared SOFA to SIRS. SOFA is sequential organ failure assessment, like for sepsis specifically. SIRS is nonspecific and doesn't have any kind of organ dysfunction in the scoring system. So they compared a score of organ dysfunction to a score that doesn't assess organ dysfunction. And then they derived Q-SOFA from that. So truly you have to ask yourself, is this a better test if they really didn't do a well comparison of the two parameters? They talk about a lot of validation studies and discriminant and concordant, and I'm not a statistician, I couldn't tell you what half those things mean, but I know that in the big words they're saying, they really didn't have comparable variables, because SIRS is not equal to SOFA. And here are all the components of the SOFA score. CNS, liver, coagulation, respiration. So what does it come down to? What would Dr. Sheldon Cooper do? So in looking at all of this information, I can say in the ED, I would definitely use SIRS plus source of infection because it's going to be the most sensitive. I'm not going to lose those sick patients. On the floors, MUSE and NEWS are very good at predicting if a patient is going to decline. So if those scores are high, be concerned and see those patients, and there are studies to validate that. And that goes back to predictive analytics, which some of you may be experiencing in your hospitals as well. ICU, a change in SOFA score of greater than 2 or 2 or greater is going to be predictive of patient declining. So I think that's a good place to use that score. As far as Q-SOFA, that seems like a more pre-screening score. Maybe more appropriate to use it in ED triage or in an EMS setting. So all my references, and then I went a little over. So I'm sorry I can't give you a minute.
We can still give you a minute.